From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners from around the world. I'm Paul Bryson, Director of the Cleveland Clinic Voice Center and your media editor for JAMA Oto. And today, I'm delighted to be joined by Dr. Trisha Wise-Draper, who is a professor of medicine and the section head of medical oncology at the University of Cincinnati. And today, we're going to be speaking about her work with Amivantamab for recurrent or metastatic adenoid cystic carcinoma. So welcome to the podcast.
Thank you.
Well, I read with interest this work, as an otolaryngologist, head and neck surgeon, and one who's been aware of some of the rare tumors that we encounter in the head and neck. Certainly adenoid cystic carcinoma is not one of the ones where we have been hearing about as many novel treatments. And so I really wanted to highlight your work and your team's work in this space and learn a little bit more and share with our listeners about this treatment for what can be a really devastating diagnosis for patients.
Great. I'm delighted to be here.
Yeah, if you would you give a little background, maybe just in broad strokes about adenoid cystic carcinoma, but then also about this new treatment, how it works, maybe how you came to try it for this disease state.
Sure. So adenoid cystic carcinoma is a relatively rare cancer. It often occurs in the salivary glands of the head and neck, although it can occur in other glands throughout the body. When it does occur, surgery and sometimes adjuvant radiation are the main treatments for adenoid cystic carcinoma, but it can recur years later. It often recurs in the lungs, sometimes in the bones, and when it does recur, unfortunately, it's not very sensitive to chemotherapy or some of our traditional treatments. Recently, there's been some development to understand there's likely two types of adenoid cystic carcinoma. That's been known for a while by pathology characteristics, but more recently, Renata Ferrarato published a manuscript that showed that type 1 ACC was more characterized by EGFR epidermal growth factor receptor signaling, as well as MET signaling, which is a resistance mechanism for EGFR. She also showed that type 2 was more characterized by Notch mutations, and therefore, because of these characteristics, we wanted to see if we could target that EGFR mechanism. And so when type 1, as I mentioned, because it does have elevated EGFR, we thought Amivantamab would be a good choice of treatment. Amivantamab is a bispecific antibody. It's currently approved in certain lung cancers, but it targets both EGFR as well as c-MET. And so the idea is if we could target both EGFR, which is upregulated in some of these adenoid cystic carcinomas, and then also its resistance mechanism with MET, that we'd have a better chance of being able to keep these cancers from progressing. Traditionally, other targeted agents, though multi-tyrosine kinase inhibitors such as lenvatinib, have had some success in adenoid cystic carcinoma, but their response rates were low. But lenvatinib probably has the longest progression-free survival, somewhere around 17.5 months. So we are hoping that these agents could come in after these TKIs and hopefully have some success in this type of tumor.
Can you speak a little bit about the inclusion criteria and about the two types of adenoid cystic carcinoma that you were looking at in your study?
So type 1 adenoid cystic carcinoma is characterized by a more solid pattern and worse prognosis by pathology. But by molecular testing, which was recently shown by Renata Ferrarato, type 1 is also characterized by elevated Notch signaling as well as MYC signaling. However, type 2 ACC, which is a more indolent diagnosis, is characterized by P63 as well as EGFR and MET signaling. And it has more of a cribiform pattern on pathology. And so when we decided to run this study with Amivantamab, which targets EGFR and c-Met, which is known to be a resistance mechanism to EGFR, we decided to use both types of ACC because we didn't really know whether they were mutually exclusive, meaning we didn't want to exclude a patient based on their characterization and then they might have had a response to the drug. So therefore, we included all patients, whether they are type 1 or type 2, but we did characterize them later on in the study. And we did find that they actually aren't mutually exclusive, meaning that sometimes they would be positive for both P63 and c-Myc, and sometimes they wouldn't be positive for either one. Therefore, we couldn't confidently say they were type 1 or type 2 just based on their molecular signature. We also included patients that had to have progressed by RECIST within 6 months, and therefore these patients had more aggressive disease that may have affected some of the outcomes on the study, but we wanted to make sure we were treating those patients that really needed treatment.
Yeah, thank you for explaining that. What did you find in the results? I'm forgetting, how many patients were you able to enroll?
So we actually enrolled 21, but only 18 were evaluable for our study. And what we found was that although the actual response rate was low, it was less than 6%. We did find that the clinical benefit was over 70%. So the best response was stable disease in a lot of patients. And as we know in adenoid cystic carcinoma, which has always been difficult to treat and shrink the tumor, stability is sometimes a win. And so we felt like there was some activity with amivantamab in these patients, and that over the long term, especially if we're able to combine it with other drugs, which it's been found that amivantamab can be combined with a lot of other treatments, especially in lung cancer, that we may be able to achieve better response rates in these patients.
Yeah, it's pretty exciting. Like you said, it seems like the lack of progression can be a win, and people can probably maintain some function and quality of life and maybe have it be more of a chronic, persistent thing as opposed to something that continues to advance and advance. As you look ahead, it's so important to get this sort of work out. And I think as we see more and more of these treatments being applied to maybe conditions we didn't think that they could be, what are you and your team sort of looking ahead to next with this agent and with adenoid cystic in general?
Yeah. So with this agent in particular, we did use the IV formulation on the study because that's what was available at the time. But there is a subcutaneous formulation now, and that's important because the subcutaneous has left infusion reactions, which has been limiting with some of the IV formulation. And so I would recommend that we go to subQ for future studies. But we really want to see what can we possibly combine it with without adding too much toxicity. So whether that be immunotherapy, which traditionally hasn't had a lot of effect in adenoid cystic carcinoma, but maybe in combination, or some of the taxane chemotherapies that have limited activity, but with combination, we may see better effects, or that be other targeted agents. One of the exciting things about adenoid cystic carcinomas, we more recently have started to see some advances. For example, most adenoid cystic carcinomas are characterized by MIB fusions, MYB, and there are MIB degraders now that are in trials. There's also Notch inhibitors for the ACC1 type. So there are some other agents that are coming out for these tumors, and hopefully by using some of these combinations, we can finally achieve better response rate.
Well, that's very exciting. Just as a surgeon that's kind of trained, and some of the things that we see are uncommon, and you don't always think that there's a ton of good options, but this feels optimistic that there's some progress being made and maybe some agents that patients can try.
I agree. I think it's a very exciting time for some of these rare tumors where we have limited patients. And so that has stalled our progress. We're finally starting to see some progress with these patients.
Well, I really appreciate your time today, and I congratulate you on your work. And,
Thank you.
I look forward to seeing more from you and your group. Any final take homes for our listeners, or any advice that you would offer, maybe if there's a patient listening or things like that? What would be the best way to kind of engaged with oncologists like yourself to see if they're a candidate for treatment?
Sure. I would say the first thing is make sure you do molecular testing. Once these patients need treatment, it's important that we know what their phenotype is so that we can determine if they can go on clinical trials. Clinical trials should always be the first thought for these patients since we know that traditional therapies are not ideal. And really just reach out to any of us. There's several head and neck medical oncologists that treat these types of tumors. And even if you are being treated outside of an academic center, your oncologist can reach out at any point, and then we're happy to give advice.
Well, it's been great to have you today.
Thank you.
Well, I am Paul Bryson, and I've been speaking with Dr. Trisha Wise-Draper about Amivantamab for recurrent or metastatic adenoid cystic carcinoma. You can find a link to the article in this episode's description. To find this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.